Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, I'm pediatrician by profession and teacher by passion. So, today, in this series of NEET SS previous year topic series, we are discussing another important topic, which is inherited bone marrow failure syndrome. It is very frequently asked and very crucial topic for your upcoming exam. So, without further delay, let's dive deep into it. That is inherited bone marrow failure syndromes. Okay, so as you can see, pancytopenia is the major thing when this things can be thought of or DDs of pancytopenia. This is approach we will use. If in peripheral blood smear pancytopenia is there, so do bone marrow. Next step, if bone marrow is hypocellular, means no cellularity or less cellularity is there, so you can think of inherited bone marrow failure syndrome with pancytopenia. First, second, acquired aplastic anemia, and third, hypoplastic variant of myelodysplastic syndrome. So, to be precise, three possibilities are there: one, two, and three. Remember this. Next, pancytopenia is there. You did bone marrow and you found cellular bone marrow. So, in cellular bone marrow, what are the things? Primary bone marrow diseases like acute leukemia, myelodysplasia. Secondary to autoimmune disorders like autoimmune lymphoproliferative disorders, SLE, vitamin B12 deficiency, folate deficiency, storage disorders like Gaucher, Niemann-Pick, and severe infections, sarcoidosis, hypersplenism. This is busy slide, but remember all the points in this slide. So in cellular bone marrow, this is very important. Okay, you did bone marrow in pancytopenia patient. So this shows with bone marrow shows bone marrow infiltration. So it can be due to metastatic solid tumors, myelofibrosis, HLH, and osteopetrosis. Osteopetrosis has been asked previously also. So this is very important. Pancytopenia, how you will approach on the basis of bone marrow. One important point, and this is previous year question, inherited bone marrow failure syndrome can manifest as normocellular or hypercellular bone marrow at early stages of presentation or in case where MDS develops. Okay, so you have to keep the high degree of suspicion. Okay, patient may have single lineage or bilineage cytopenia at the presentation and gradually develops pancytopenia over time. So to start with, it may be present with like isolated HB is decreased, TLC isolated decreased, or platelets isolated decreased. So it may progress over time. So let's talk about inherited bone marrow failure syndrome. So these comprise of 30% of bone marrow failure syndrome. This figure is important, 30%. How we will confirm them? By whole genome exome sequencing, and gene specific panels are there, so we can do this. So let's dive directly deep into the important inherited bone marrow failure syndrome. Obviously, we will discuss briefly for other syndromes, but for as of now, we are discussing Fanconi anemia. Okay, so Fanconi anemia frequency is like 1 in 20,000. Carrier frequency 1 ratio 200 to 300. Approximately 20 genes, 22 genes are there. FANC gene, we will discuss them later. They are associated with tumors like MDS, AML, epithelial tumors. Okay, so what happened? Let's understand the pathophysiology, which is very interesting. If normal FA gene is there, they code for DNA cross-link and repair. Understood? If abnormal FA gene is present, this process, which process? DNA cross-linking and repair is defective. So, this can be enhanced by DEC and MMC drugs. Okay, so if this is defective, then manifestation of Fanconi anemia will develop. What are the manifestations? We will discuss later. One important concept, and again the previous year asked question, is complementation. So what is complementation? If normal cell get fused with Fanconi anemia cell, the corrective effect of chromosomal fragility is seen, which is seen as complementation. So complementation is seen in Fanconi anemia. Okay. So, the triad of three things: bone marrow failure, congenital anomaly, and increased chromosomal fragility is hallmark of Fanconi anemia. So, what are the FA genes we have discussed so far? There are multiple. I told you 22 genes. FA genes like FANACA, CB, CC, CD1, BRCA2, CD2, CE1. Obviously, FAN is prefix, NCI. Some genes are like FA-like gene. FANCO, RD51C, FANCS. You don't have to remember all the list. What you have to remember, the most common gene is FANCA, which is 64%. FANCC next is 14%, and FANG is 9%. Okay, so as we discussed earlier also, these genes involved in DNA damage recognition and repair. So complexity and heterogeneity of disease is seen. We'll discuss later. Okay, so this is actually we are directly into clinical features of the disease. So most common is skeleton anomaly in Fanconi anemia. Again, the previous year question. So what are the anomalies like absent radius, thumbs are hypoplastic, supernumerary bifido absent, skin showing hyperpigmentation, cafe lid spots, vitiligo, height, short stature. Also, growth hormone and thyroid deficiency. As you can see in this picture, this baby is short stature. Okay, then this baby, classical facial features we'll discuss later also. This is actually microcephaly, broad nasal base, epicanthal fold, micrognathia is present. Okay, then we can see thumb. Thumb like it is actually attached by like a thread, and these are capillute spot. So this image is very important, which actually deposit the Fanconi anemia phenotypic features. Important. Male patients of Fanconi anemia have underdeveloped penis, undescended atrophic absent testis, hypospadiasis, phimosis. All are infertile. Again, this is very important. All are infertile. This is again very important. Female can have manifestation of vagina, uterus, and ovary, and all have reduced fertility. So men has are all fertile and female have reduced fertility. So again, as we discussed, facial features like broad nasal base, microcephaly, small eyes, epicanthal fold. Next, kidneys. So kidneys may be ectopic, pelvic, horseshoe-shaped kidney, hypoplastic, dysplastic or absent. Approximately 10% of patients of FA are congenitally delayed. This is again very important. In 10% cases, mental retardation is seen in Fanconi anemia. Neonate with FA, Fanconi anemia has IUGR, low birth weight and vectoral anomaly. Okay, so these were skeleton features and systemic features. Next, what about bone marrow failure? Because it is classified under bone marrow failure syndrome. So it appears in first decade, not at birth. Important. First, thrombocytopenia or BC macrocytosis and increased fetal hemoglobin seen as first manifestation, again important and has been asked previously also. Next is neutropenia, anemia, and later aplastic anemia. So this sequence of hematological abnormalities in Fanconi anemia is seen, and it's very important. Okay, cancer risk. I told you earlier, na, because it has cancer risk, malignancy risk, Fanconi anemia. So the most common anemia is uh, head and neck carcinoma, which is actually squamous cell carcinoma of head and neck, 600-fold higher incidence. So this is maximum associated with Fanconi anemia and associated with HPV. So the important point, we have to vaccinate the children with HPV. Carcinoma upper esophagus, carcinoma vulva, NS lower esophagus, solid tumors at early age. This is important. Liver tumors associated with androgen therapy. We'll discuss in treatment. Androgen therapy is used in treatment. So palliose hepatis is reversible condition with this. 40-year leukemia risk is 33%. Again, fact-based question. And MDS AML risk is increased. So why we are discussing this? Because screening protocol according to this will differ. So we'll see later. Okay, so diagnosis. This is golden statement I have written in red. The Fanconi anemia should be considered in all children and young adults with unexplained cytopenia. Okay, so if you found one child which has cytopenia, so you should consider Fanconi anemia as your differential diagnosis. So you are in your OPD, you found abnormal lab finding like pancytopenia, and you found physical anomaly like thumb anomalies, you found typical facial feature, short stature, and other systemic anomalies. Your suspicion is very high for Fanconi anemia. So what you will do next? This is question. What you will do next? We will do lymphocyte chromosomal breakage study with MMC and DB. These are two agents with increased in vitro chromosomal breakage. So this is important. Next step is lymphocyte chromosomal breakage study. Okay, so what we will found in the study, increased chromosomal fragility. So this is very important. In this disease, it is pathognomic. In which peripheral blood lymphocyte and skin fibroblasts. So this slide is very important as per diagnosis is concerned of Fanconi anemia. Important concept. So just see this line, a golden statement. 10 to 15% of patients with suspected Fanconi anemia have somatic mosaicism and may not show the characteristic high degree of chromosomal fragility in their lymphocytes. Lymphocytes may chromosome fragility is normal. So what we will do? We next question. Then we will do peripheral lymphocyte chromosomal fragility, okay, which is normal. Then we'll do testing in skin fibroblast. Okay, amazing, na? Okay, what is the test of choice then? Is this chromosomal breakage study? No. Test of choice is, this is actually NGS gene panel and whole exome sequencing. Next generation sequencing and whole genome exome sequencing is the test of choice, but you can start with this, okay, this lymphocyte chromosomal breakage study. So next step is lymphocyte chromosomal breakage study, but if it has been asked that which is test of choice, then NGS gene panel and whole genome exome sequencing. What are other tests you will require? High resolution copy number variance analysis, genome wide search, CT, MRI, USG, endocrine evaluation as the part of diagnosis. Okay, this is very important. Screening. So, in Fanconi anemia patient, how you will proceed with screening? Okay, so screening PBF every 3 months, bone marrow every year, glucose annually or biannually, thyroid workup annually, solid tumors annually, oral cavity examination after 10 years or post stem cell transplant, gynecological cancers annual, and in siblings you have to test chromosomal fragility, HLA typing. Okay, what is the treatment? Treatment is a hematopoietic stem cell transplantation, only curative therapy for Fanconi anemia. So what we would use, modified reduced intensity regimen that include fludarabine, low dose cyclophosphamide and anti-thymocyte globulin or low dose busulfan. Why we are giving modified reduced intensity regimen? Because already these patients are susceptible to develop MDS and AML and different type of cancers. Second, androgens. So what androgens do? They are just bridge between this HSCT, stem cell transplant. This is bridge therapy. So response is seen in 70% of patient. HB increased in 1 to 2 months, followed by WBC and platelet. This sequence has been asked. Androgen increased HB first. Okay, if androgens are started at low dose, they should be increased or scaled up in next 3 to 4 weeks. If they have been started in high doses, they should be slowly reduced to the maintenance dose. Drugs are, which is important, oral danazol and oxymetholone, and androgen therapy is not curative as I told you earlier. GCSF and EPO combination is also used. Okay, now we'll discuss other inherited bone marrow failure syndrome. Just brief overview of them. Okay, so just you can see Fanconi anemia we have seen. Just pay attention on this. This table is very important, straight from Nelson textbook of Pediatrics. Sherman Diamond syndrome. Okay, so this syndrome is autosomal recessive. What are the gene? SBDS, DNCG, and EFL1, and this is due to ribosomal biogenesis. Dyskeratosis congenita, this is X-linked recessive. Gene is DKC1. Telomere maintenance and ribosome biogenesis is the main culprit. Dyskeratosis congenita also is autosomal dominant, autosomal recessive. These are the genes. Congenital amegakaryocytic thrombocytopenia. This is autosomal recessive. Gene is MPL and hematopoietic cytokinin receptors. SRP72 associated with hereditary aplastic anemia. This is SRP72 gene, and ERCC6L2 associated with aplastic anemia. This gene is same. So in this busy table, what you have to remember is we will highlight and only we will remember this. So this syndrome you have to remember. Okay, this is autosomal recessive. These genes you have to remember. Okay, and this keratosis congenita, just remember most common is XLR, other AD and AR. Gene, just remember DKC, TINF, and these genes. Congenital amegakaryocytic thrombocytopenia, just remember MPL, and other two diseases actually genes are same. Okay, so telomere maintenance or shortening is seen in this keratosis congenita, which is important. So from this table, these highlighted are the take-home points. Okay, again, next is THPO associated hereditary aplastic anemia. So again, the gene is THPO, same. Reticular dysgenesis, AK2. Cartilage hair hypoplasia, RMRP, POP1, NEPRO. Okay, Pearson syndrome. So maternal mitochondrial DNA, it is important. Familial thrombocytopenia with predisposition to AML, this is autosomal dominant. RUNX1 CBA2 gene, ETV6 gene, and GATA2 associated disorders like Monomax syndrome, Amberger syndrome, familial MDS syndrome, GAT2 mutation. This is very important, has been asked previously also. Bone marrow failure and diabetes, gene is DUT. This again one-liner question. Familial MDS and AML, familial MDS and AML, others like this gene. So from this busy table, what we will see, the important thing, Like as you can see, we'll just highlight important thing from this table. So let's see here. So in this table, this is THPO, it's sufficient. Cartilage here hypoplasia. It is autosomal recessive. These are genes are important. Pearson syndrome. This is maternal mitochondrial DNA. And again, familial thrombocytopenia is autosomal dominant. These two genes has been previously asked. And this again, here of this slide is GATA2 associated disorders. So GATA2 is self-explanatory and these are disorders. And which is associated with bone marrow failure and diabetes with gene DUT. So just remember these highlighted points in this busy table. Okay. Next, again. So as we can see, this is another table containing Sickle syndrome. So Sickle syndrome, multiple genes are there, and these have DNA damage, sensing, repair, checkpoint signaling activation. So multiple mechanisms there. SHIM-K immunoosseous dysplasia, SMARCAL1 gene is associated. Dobovitz syndrome, the genes has been previously asked. NSUN2, LIG4, this is cytosine methylation, various RNA types. And Rothmund-Thompson syndrome, autosomal recessive, gene RECQ-L4, and Nisman-Brakes syndrome is NBN. So just we'll again remember the important point from this slide. Sickle syndrome, just remember this is part of this pancytopenia spectrum. Just remember the name and just remember this as a gene. Just remember this gene. Just so in this busy slide, I'm bugging you with lot much of information, but trust me, these question has been asked, and around these questions and around in this table, other are potential MCQs or questions. So just pay attention of highlighted area. Okay, so clinical manifestations. So this is easy slide. Okay, so as we discussed earlier also, Fanconi anemia we discussed, short stature, hypoplastic, so we have discussed. Okay, we'll directly go to disc keratosis congenita. So what is the triad? Triad has been asked. So skin pigmentation, nail dysplasia, oral leukoplasia. Other things, short stature, low birth weight, pulmonary fibrosis, stenosis of esophagus and liver fibrosis. Laboratory finding, obviously pancytopenia, macrocytosis, HbF, and very short telomere. This is different. Again, diamond blackfell anemia is low birth weight, short stature, developmental delay, anomaly in craniofacial skeleton, and laboratory findings like red blood cell adenosine deaminase, macrocytosis. This is there. Okay, Sherman-Diamond syndrome, exocrine pancreas deficiency, which is important, failure to thrive, malabsorption, short stature, and neutropenia, low serum isomaleage, low serum trypsinogen. So in this busy slide, what we will remember, we have discussed Fanconi anemia, which is important. Okay, in this keratosis congenita, we have to remember this triad, which is important. Okay, pulmonary fibrosis, stenosis of esophagus. This much is important, and laboratory findings very short telomeres. Diamond blackfan anemia, just remember this developmental delay, short stature, and red blood cell adenosine deaminase macrocytosis. This you have to remember. Schwarzman-Diamond syndrome, just remember exocrine pancreatic insufficiency, malabsorption, neurodevelopment disorders, low serum amylase and low serum trypsinogen. So just remember these highlighted points, you will be good to go. Again, the next set of syndromes which are associated with pancytopenia, severe congenital neutropenia. Okay, so this is as name suggests recurrent infection and neutropenia is there. Congenital amegakaryocytic thrombocytopenia, as we discussed in previous table also, this is non-syndromic and psychomotor developmental delay. GATA2 deficiency, lymphedema, immunodeficiency, atypical mycobacterial infection, neutropenia, anemia, and thrombocytopenia. SMAD9 or SMAD9 L disorder, Mirage syndrome. So this is Mirage has been asked previously. What is the full form? MDS, infection, restriction of growth, adrenal hypoplasia, genital phenotype, and enteropathy, and ataxia pancytopenia syndrome. So SMAD9L. L is important. This has been again asked. Cellular atrophy, bite matter hyperintensity, gait disturbances. Hemicomb associated disorders. This is actually radioulnar syntosis, clinodactyly, and Pearson syndrome is pancreatic insufficiency, failure to thrive, microcephaly. So again, this is busy slide, and in this slide, what we'll see, just we will remember again highlighted area. So GATA2 deficiency, what are the features? Immunodeficiency, atypical mycobacterial infections, SMAD9 associated with Mirage syndrome. You have to remember full form of Mirage. Just remember ataxia and pancytopenia, SMAD9L. Okay, and ME coma associated with syndromes like radioulnar stenosis, Pearson syndrome associated with pancreatic insufficiency. Okay. Okay, last but not the least, the Canadian Society Inherited Bone Marrow Failure Syndrome. This is actually classification criterias which are unclassified. Okay, so what you have to remember this: fulfill. If they does not fulfill the criteria, fulfill both of the following. Okay, so this has not been asked, but just remember, just go through this table and. One question might be from this table. So this was it for today. This was inherited bone marrow failure syndrome. We discussed Fanconi anemia in detail, and we discussed other syndromes as per their genetic genes point of view and their clinical features in brief. This is very important topic, and I hope uh, you will get 3 to 4 questions from this, and just go through this slides or this actually YouTube video again, and you will get clarity. Okay, so as we are discussing this is amazing series of NEET SS Pediatric. Okay, so we'll see in upcoming days. We'll discuss many more topics like this, and stay tuned. Do subscribe, do like, do share, and yes, we'll meet in another exciting topic of pediatrics. Till then, bye bye.